And then just show the previous couple slides, the previous slides. Just show them with a few seconds in between. Okay,
Yeah.
thank you.
Yep. No worries.
I can't type, otherwise I wouldn't interject.
Yeah. No, it's a good point. Short-term memory loss, Hafez. It's all the sevoflurane I inhale. Okay, so we run a restrictive fluid strategy, and again, as I was saying last night, there's this gradual trend towards restrictive fluid strategies with abdominal surgery, bowel surgery, and of course other types of surgery like lung surgery. But we believe excessive crystalloid impairs wound healing, increases anastomotic breakdown, and can increase the incidence of pneumonia. So that's why we run them restrictively. It's not as critical as it is, say, for the pneumonectomy, as we talked about yesterday. But the aim is no more than 30 milligrams per kilogram of positive fluid balance in these patients. And as I mentioned, inotropes may help to keep the blood pressure up and in so doing reduce the amount of fluid we need. Maintaining normal hemodynamics is very important in this surgery because hypotension threatens the blood flow to the stomach drawn into the chest. So what happens is the surgeons resect a bit of esophagus where the cancer is, and then they pull the stomach up into to reanastomose the esophagus, and that puts a bit of a stretch on the stomach, a bit of a stretch on the stomach's blood supply. And one of the reasons these patients are thought to get anastomotic breakdowns, or one of the independent risk factors, is periods of hypotension intraoperatively. So it's very important to keep their blood pressure up, keep their MAP above. I think it's 65 is the if I remember correctly is the number we want to keep above, because I think there was a study showing that a MAP below 65 was a predictor for anastomotic breakdown. So inotropes are helpful. Some surgeons, in the same way that plastic surgeons used to get a bit upset about us giving vasopressors, so do some of the surgeons. The reason being that if we give noradrenaline or a lot of phenylephrine, we cause splanchnic vasoconstriction, which theoretically can then lead to anastomotic breakdown. But it becomes a catch-22. We need to maintain blood pressure. We don't want to give too much fluid, but yet they don't want us to give inotropes. I only worked with one surgeon who was fussed about this out of the 5 I worked with in Canada, and certainly the surgeon I worked with in Australia never tried to stop us using it. So I think it's more of a theoretical issue. But again, if you're running an epidural, they will get hypotensive, and as I said, they're often dry. And when I say dry, I'm not talking dry like a patient who's fasted overnight is dry. These patients might be intracellularly dry because they've been not eating and drinking well for a few weeks. So ideally, they're optimized before we put them to sleep, and that's not a huge issue. But just keep that in mind if you ever do these cases. So that's esophagectomy. This talk was originally given in Rwanda, which is why I'm showing pictures of gorillas. Mediostenoscopy is a common type of thoracic surgery, and it's basically where they take a device that looks a lot like a laryngoscope called a mediastinoscope, and that's this device. This is obviously the head of the patient, and the surgeon makes a cut above the manubrium of the sternum and shoves this thing in, and then either puts a camera in and looks, or just looks himself or herself through the eyepiece, and it's commonly done for lymph node biopsy. So one of the common procedures we used to do in Canada was a mediastinoscopy, biopsy, frozen section, and then if the lymph nodes were negative, they would go ahead and operate on the lung. If the lymph nodes were positive, then they may not resect the lung because it may be that the patient needs some chemotherapy first. As you can see from this picture, though, there's a lot of structures here. There's the great vessels, there's the innominate vein, there's the aorta, there's the innominate artery, there's the pulmonary artery, the azygos vein, and there's a recurrent laryngeal nerve. So there's a lot of things that can go wrong. during a mediastinoscopy. One of the people I worked with in Canada said he had seen someone tear the pulmonary artery doing this procedure. What it looks like on the screen, and hopefully it is on the screen and they're using a camera so we can watch, they just dissect through all this fat and tissue, and they do a blunt dissection, pushing tissue apart until they get to the lymph nodes. But every now and again they use cautery, and every now and again they can hit a big vessel. And what they very commonly do is obstruct the innominate vein. And so you'll see that when you put your arterial line in, it should always go on the right side. So when it flatlines, you can say to the surgeon, hey, you're obstructing the innominate vein. If you decide not to put an arterial line in for reasons being that it's a very healthy patient and they haven't been in there before, because if they've been in there before, it's almost contraindicated to going there again because it's very scarred and very difficult. But you can put your pulse oximeter on the right. What I usually do is put an arterial line on the right, a pulse oximeter on the left, because they can kink off the innominate. They can also kink off the subclavian artery, and if they do it for too long a period, then we need to tell them to stop doing what they're doing and give the arm a chance to have some blood flow. So, as I said, the reason they do it is to biopsy lymph nodes, to check for spread prior to resection of what they're resecting, which is usually lung. They can damage the major vessels, as I mentioned, and they often occlude the brachiocephalic artery. So definitely you want to monitor the blood flow to the right upper limb. Other things they can do on a bad day is cause a pneumothorax, damage the recurrent laryngeal nerve. As you saw, it's very close. We'll just go back and look at that picture. It's very close, so they can damage that, and obviously hemorrhage and hemothorax, because the lungs are obviously on either side. So when people are learning, that is probably the most likely time they're going to cause some damage. But it's not, just to go back, it's not a particularly painful procedure, and certainly once the procedure is done, these patients don't need a lot. If it's just a straight mediastinoscopy and everything goes well, they often go home or stay in one night, but it's certainly not particularly painful afterwards. So anterior mediastinal mass is the next type of tumor that we see in thoracic surgery. And this CT scan shows a nice anterior mediastinal mass. You've got lung here, obviously the spinal cord showing this is posterior. This is the mass. And this is the mass compressing what should be an airway. So they can cause some obstruction of major structures. And when we see these patients preoperatively, assessment is very important. Assessing their airway, is the trachea deviated, or is there imaging on the CT scan showing compression or deviation of the trachea? Does the patient have any stridor? Often these patients will have stridor, or when you examine them, get them to take a big breath in, you'll hear some stridor. Do they get breathless lying flat, which can be a sign that it's compressing their airway? If they get superior vena cava syndrome, that's where the mediastinal mass is compressing the superior vena cava, and when they lie down, it can cause some problems, such as facial plethora because of venous obstruction. Likewise, you can do a Pemberton sign to check when they're sitting up. That's where you get them to put their arms up in the air and see if their face turns red, and again it's due to obstruction. And I usually get them to put their arms up in the air and then take a big breath in, just to see if they do have any stridor or symptoms. The CT scan is very helpful in these patients, as we'll come to. So with the anterior mediastinal mass, the two major concerns are airway compression and cardiovascular compromise. But from our point of view, the first issue is airway compression. So if they have a history of dyspnea...
Can you hear me?
Yeah.
Oh, I'm sorry. I don't know why I cannot type in the chat, but a couple of people and me are having a difficult time hearing you. are it's very choppy. Are you where are you? Are you still in Nablus?
No,
Are you?
I just arrived in Ramallah.
Oh boy, are you downstairs or in your room?
I'm upstairs just because I couldn't work out how to log in, but I can try and go downstairs and see if
Oh,
it's
they have yeah. It's called Do Re Mi 1 2
yeah,
3 4 or something like
yep.
that. Can we take a quick break, you guys, while Dr. Rosen goes downstairs? Because I think the sound. Mine in Jerusalem says the sound is good. Dia and Hebron and Ruba, also in Jerusalem or somewhere close to that, are saying that the audio is very choppy, and me too. And I have a very fast, so
Right, because it was telling me, my computer was telling me it was a slow connection, but we'll see how we go. Okay, so yeah, so as I was saying, mediastinal mass, one of the major concerns is airway compression. And so on history, we ask about things like dyspnea, stridor, cough, especially when lying flat. These are ominous signs. So so just well, there's nothing to really recap. Hafez just asked me to recap, but I'm recapping now. When I talk about, so I was saying the considerations are airway, cardiovascular compromise, SVC syndrome. Our major concern is airway compression, because obviously we need to control the airway in these patients. So and I'll talk about the problems, one of the concerns about this on the next slide. But they say from studies, if the patient has dyspnea or stridor when lying flat, that's an ominous sign. And in some study, I think one or two studies, that had been shown to be a predictor for a worse outcome. And then symptoms of SVC syndrome, things like a headache, visual disturbances, facial, neck, or upper limb edema, they're all suggestive of SVC syndrome. And as I mentioned, you can assess for Pemberton's sign, where you get them to put their arms up in the air and take a big breath and see if they get breathless, and see if they get some stridor as well. Yeah, they're a little scary when they have these signs. The other thing we like to see on these patients is investigations, and spirometry is useful, but it's not as helpful, I guess, these days as a CT scan, and it's not reliable. But it is something that comes up in multiple choice exams, and it is something that's therefore we have to know about. But it's the sort of thing that usually you flip through the patient's chart while you've already anaesthetized them and look at the curve and go, oh yeah, that makes sense because of their pathology. But really, these days, a CT scan is the test that's going to be most helpful. And sometimes, if the head and neck surgeons or ENT have seen them and done a nasendoscopy, that may also be helpful. The reason CT is helpful is because we can get anatomy of the patient's airway and also see if the mediastinal mass is involving the heart. Sometimes these cases are so bad that they need to be done on cardiopulmonary bypass because the mass is involving the heart or very close to the heart. So it's very important when we have these investigations that, particularly if it's a bad CT scan, and I've got an example coming up, that we have a discussion with the surgeon about our plan to put the patient to sleep, and the surgeon's plan to control the airway. Because one of the major concerns with anterior mediastinal mass, particularly when there is tracheal compression, is losing the airway. So there's a concern that when the patient is sitting up and has normal muscle tone, the surrounding muscles are suspending the mass off the trachea, and that's one of the reasons why the trachea remains patent. However, when we anesthetize these patients, particularly if we paralyze these patients, we lose that tone and the mediastinal mass. Bearing in mind our patients are now lying on their back, they're going to be supine when we intubate them. The mediastinal mass can then collapse the airway and we lose the airway. Because these are often tracheal or distal tracheal or at the carina or the bronchus, intubating may not be the answer, because if it compresses the corona, even if you have an endotracheal tube in, you're not going to get past the mass. And so these patients can get into trouble. And if their mass has been there for a long time, these patients may have a component of tracheomalacia, just like you see with a severe thyroid disease. And so we need some way of splinting the airway. So the way to discuss with the surgeon is to make sure that you have someone who can put a rigid bronchoscope in a hurry, if this happens on induction. And so you shouldn't induce these patients until you have a surgeon, a thoracic surgeon or an ENT surgeon, who has a rigid bronchoscope ready to go in the case of emergency. Sometimes they say if the patient crashes on induction because of the compression of the mass and you can't control their airway, you can try and flip them prone. But obviously controlling their masking them prone is difficult. But if you've already intubated, you can try and flip them on their side or prone. Probably on the side would make more sense. And the other thing that you can do in an emergency is cardiopulmonary bypass. You'll read things in books like cardiopulmonary bypass on standby. If you think it's really likely the patient's going to arrest on induction. One of the problems with this is I don't know if any of you have ever seen someone go on cardiopulmonary bypass in a hurry, but even in the best hands, it takes 10, 15 minutes. And if you've got no airway, that's too long. So really what I think the sensible thing is if you think they're going to need it on induction, then rather put them on before induction, just put them on bypass. So the surgeons can do it with local anesthetic, and they can put lines in the femoral area. Sometimes we used to get them to prep the groin. I think I saw one case where they did actually put guide wires in the femoral artery and in the internal jugular vein, just in case. But again, this is all something you talk to your surgeon about. It is very uncommon that this happens. I probably in my fellowship did about 8 or 9 of these cases, and they were all okay. And when I talked to Peter Slinger, my consultant who's done several of these, he'd never seen anyone collapse on induction, and the ones they thought were really high risk, they went straight onto bypass off the bat. So that's just a bit of background, and we'll talk about techniques in a minute, but that's why discussing it with the surgeon is very important. If it's just a biopsy of a mediastinal mass, often we can avoid a general anesthetic and just use some midazolam and ketamine with local anesthetic with the surgeon, or if it's an adult, often just local anesthetic, and avoid putting these people to sleep. And that obviously makes our life a lot easier if we don't have to put a breathing tube in these patients. So this is a picture of some spirometry curves, and this is the classic curve you see with anterior mediastinal masses. So on the left is normal. Remember normal, inspiratory limb. Okay, you've got volume here and flow here. It's called a flow volume loop. Volume is, as the patient breathes in, it should go this way. And then as they breathe out, you get the effort independent part, and then the effort dependent part, and then the effort independent part. Now, when you have an intrathoracic bronchial obstruction, that is a mediastinal mass pressing on your trachea, on your bronchus inside the chest. So inspiration, when you breathe in, what happens is you expand your chest because you create a negative pressure. That helps lift the mass off the trachea or the bronchus, and that's why you have a normal appearing curve. But then when you breathe out, you create a positive pressure inside the chest, and that sort of pushes the mass onto the trachea, causing obstruction, and that causes this classically flattened curve. And then you complete exhalation. So that's a sign of intrathoracic obstruction. If it's an extrathoracic obstruction, as you might see with a thyroid mass, a massive goiter or something like that, it's the opposite effect. So you breathe in and you have compression because the negative pressure and the expansion of the trachea is inside the chest, but outside the chest that doesn't happen. But then when you breathe out, your positive pressure inside the trachea as the air moves out, pushing the mass off the trachea and re-expanding the trachea, and you get a more normal looking expiratory curve. So that's just a bit of trivia. As I said, it's useful only in exams. I don't think we make decisions to proceed on surgery or make diagnoses of where a mass is based on these curves, but it may provide a clue, but we're going to do a CT scan. So what are you going to do if you have a CT like this? So this is your lung, and your heart is somewhere in there. This is your aorta, but this is your mediastinal mass, and this really squished thing here is your trachea. So that's a little scary, because this is exactly what we were talking about on the previous slides. You want to know if the patient has tracheal compression and symptoms. You'd think they'd have some symptoms with a mass like this, some degree of stridor. So you have to come up with a plan, because this person is probably the person that we would say is going to be high risk of compression. And this is moving further distally, and you can see the bronchi. This person is potentially at risk of when we put them to sleep, this mass falls onto their trachea and compresses it completely. So what else might you want to see? This is all very interesting. Great, they've got this compressed mass, and we can see in this sort of cross-sectional or transverse view that they have a compressed airway. But what I want to know is first of all, is there anywhere where the airway is almost completely obliterated, and can I get an endotracheal tube in? And bear in mind, when you do a CT, it takes slices, so you're missing bits of the airway. So there might be parts of the airway that look really bad. So I'd really like to see a longitudinal view or a coronal view. This is a coronal view, to see the whole trachea and just get some idea of A, is this involving the heart, and B, what's the rest of the airway like? And you see here, it's the coronal view. It's pressing on the airway, but it's not terrible. This is the carina, and this looks again, it's slices, so the carina is patent, but it just looks like there's something there just because of the view we have. But you think, okay, well, hopefully you can get a tube in there because it's open, and that's reassuring to know. So you want to see both views of the airway, and then you want to talk to your surgeon and make sure you have a good plan. So when we do these patients, maintaining spontaneous breathing is paramount, okay? And again, that's what I was saying before about this concern that if we paralyze them, well, there's two things. One is the patient is spontaneously breathing now and they haven't stopped breathing, therefore they can maintain their own airway. So if we take that away from them and we lose their airway and the mass falls on the trachea, we're in trouble. But because we know that on their own they can keep breathing, why take that away? Why not just let them keep breathing and then we slip a tube in? So there's maintaining spontaneous breathing is very important. And the other thing is, as I said, muscle relaxation is thought to potentially cause a loss of what other tissue is suspending that mass, and it can cause the mass to fall on the trachea. So the two techniques then would be an awake fiber optic intubation or an inhalational induction. There is a theoretical risk with inhalational induction, and again that is because when we give our volatile anesthetic, particularly in a high dose, to do an inhalational induction, we do cause some degree of muscle relaxation. You know this, right? You learn about this when you learn about your volatile anesthetics for your Part 1 exam. They potentiate neuromuscular block, and they do cause some degree of skeletal muscle relaxation. So the concern is the same as the concern with muscle relaxants, although not to the same degree. However, as I mentioned, when I asked my consultant this, he'd done multiple of these and not had any problems. And the textbooks do mention to exercise caution. So so my preferred technique is inhalational induction, but as I said last night, that's because I do a lot of them doing pediatrics. One of the key things when you do an inhalational induction, especially in some of these patients who might be obese or have sleep apnea, is that we really have to avoid partial obstruction of the airway, because that can cause large negative pressure. If the patient starts snoring because of upper airway obstruction. They create large negative pressures, and that can cause some collapse of the airways, particularly if there's any part of the mass that's suprathoracic or extrathoracic outside the chest. But it can also draw the mass onto the airway. So how do we avoid this? Well, when the patient starts to fall asleep and they start snoring, we put a nasopharyngeal airway in, sometimes a nasopharyngeal airway in each nostril, so in both nostrils, because as you know, patients don't tolerate oropharyngeal airways when they're half awake, whereas they will tolerate a nasopharyngeal airway, especially if you warn them, you explain to them they might feel something in their nose, and you can use a bit of local anesthetic like lignocaine gel to help them tolerate it. And then as they get deeper, put an oropharyngeal airway in, and then let them get deeper. Then spray their vocal cords, and then intubate. You can give a little bit of fentanyl or something like that, but it depends how nervous you are. If you're very nervous, I would just stick to gas so that you don't cause any apnea. As I mentioned, you have your surgeon ready with a rigid bronchoscope and a jet ventilator, so you can jet down the rigid bronchoscope if you need to. Connecting the bronchoscope to the side, our anaesthetic circuit to the side port of a rigid bronchoscope works well in children, but unfortunately in adults it doesn't work that well because the airway is bigger and there's usually a massive leak. So that's why we tend to jet ventilate. But certainly in an emergency you can try, but you generally have to hold the oxygen flush while you squeeze air down. So those are the two techniques: awake fibre optic, and again you put your breathing tube in, hook the patient up to the circuit, put them off to sleep, make sure they can breathe, or you do inhalational induction. And then I guess it's a little tricky as to what you do next. Now you've got your tube in, can you paralyse? If the mass is past the tube, are you game to paralyse? What do you do? And again, as I mentioned, it's because loss of the bronchial smooth muscle tone under anaesthesia can increase the compression. And when we paralyze the diaphragm, we reduce the transpleural pressure gradient, which helps dilate the airway. So I think the safest technique is, once you have your tube in, is just gently take over the ventilation and make sure you can ventilate with positive pressure, so squeezing the bag slowly and making sure you're getting good chest movement. Again, your surgeon's ready to get in there if there's any issues. And then if you need to paralyze, you can paralyze with a short-acting agent. If the patient's going straight onto bypass and you've decided that, you can let the surgeon start dissecting with no paralysis. But if you can positive pressure ventilate them, you can at least give some opioid, give a generous dose of opioid, because you can ventilate them. Arterial line in these cases is essential, obviously, because you want the earliest sign that they're starting to get compression of the great vessels. It's always good to have a lower limb venous access, so you might put one in the hand, but also put one in the foot, because if there's superior vena cava involvement and the surgeon needs to clamp the SVC at times when they're operating, you have no intravenous access. So you need to get one in the foot as well. One of the issues with superior vena cava syndrome is they get upper airway edema, head and neck edema, and also edema of the airway. And so they can have post-operative airway swelling, particularly if the surgeon has to clamp the SVC to resect some tumour for like half an hour or an hour or a longer period. And so that's something to consider, whether or not you want to extubate these patients or leave them intubated. They say, I think, if you leave them sitting up for about 4 hours afterwards, any edema should resolve. But that's just something to keep in mind. And as I mentioned, if they do collapse on induction or you cannot ventilate, try turning them lateral, try sitting them up, or in worst case, turning them prone. And if this fails, then the surgeon has to, obviously we talked about rigid bronch, but the surgeon may have to just do an emergency sternotomy and lift the mass up off the heart, and because a rigid bronchoscope will help with your airway, but it's not going to help if the mass is pushing on the blood vessels. So you really need surgeons who can do that and do it in a hurry. And as I mentioned, if you're thinking about bypass, it should be done at the start of the case, because crashing onto bypass is ugly, and it's never as fast as the books say, especially because the circuit is not usually sitting in the operating room. You've got to get your perfusionists, and if it's a surgeon that's an upper GI surgeon and not a cardiac surgeon, then maybe they're definitely not going to be as quick. The thoracic surgeons in Canada did put patients on bypass, but they weren't as fast as cardiac surgeons doing it. So how do we wake these patients up? Well, ideally sitting up, because we worry about the swelling. We want them awake, we want them warm, we want them pain-free, and we want full muscle strength. So again, this is where a nerve stimulator is very helpful. We make sure that we are ready for reversal if we gave paralysis, and we reverse them, and then make sure they're very well reversed. If there's concerns about airway swelling, we can leave them sitting up for a few hours before we extubate and give a dose of dexamethasone at the start. The other technique that some people use if they're really worried about airway swelling and it was a difficult intubation is to leave an Aintree catheter, which is a long sort of airway exchange catheter that you can get some degree of ventilation down. Cover that in local anaesthetic gel, stick that down your tube, pull your tube out, and use it as a way to find the airway again. But I think in these cases, you really want to, you don't want to have to re-intubate in a hurry. So I think that taking time, maybe sometimes taking them to intensive care and extubating them more slowly in intensive care. But obviously your anaesthetist has to be around, and ideally your surgeon has to be around in case there's any problems. The mediastinal mass should be gone at this point, so hopefully there won't be any cardiovascular collapse. But as I mentioned, sometimes they have a bit of tracheomalacia if the mass has been there for a long time, and so you may get into trouble. But for the most part, the extubations tend to be fairly straightforward. So just to summarize with these thoracic cases, preoperative assessment is very important in formulating the anaesthetic plan, and I think this last case helped illustrate why that is the case. We commonly use epidurals for thoracotomy, but there are alternatives. We tend to run restrictive fluid management for lung resection and esophagectomy. We don't paralyze at induction with anterior mediastinal mass resection, and we maintain spontaneous ventilation. And I have just a few practice questions, which I'm going to throw at you, which we'll see if you remember anything that we talked about both today and on the previous lectures. So negative pressure on an underwater sealed drain is contraindicated with A, lobectomy, B, pneumothorax after 5 days, C, removal of pulmonary hydatid cyst, or D, pneumonectomy. So I've got a couple of answers come in. Feel free, people, to throw your answers down in the chat section. Okay, I think we've had a couple of answers for D, and if everyone agrees, I think D is definitely correct. And we talked about why that was. When you have a pneumonectomy, it's good to let the serous fluid build up on that side of the lung and organise. And if you put your chest drain on suction, which is what negative pressure is, there is a risk of causing cardiac herniation, and that causes kinking of the major vessels and is life-threatening. So that's correct, those people who put D. Okay, this one I asked last week, or the first lecture I gave. Let's see who remembers. During anaesthesia, using positive pressure ventilation in the lateral position, so right lateral because left side uppermost, what is the fractional blood flow to the left lung? Is it 20%, 35%, 45%, 55%, or 60%? remember the right lung's the bigger lung, the left lung's the smaller lung. So when you're supine, the right lung has more blood flow. But when you go lateral, it changes a little bit. I'll just let people put their answers up. Okay, so the answer is B. Remember, 55% to the right, 45 to the left when you're supine. When you go left lateral, you make 55 to the left and 45 to the right. When you go right lateral, you make 35 to the left and 65 to the right. So the answer is B. The way I remember it is it's easy to remember 55, 45, right, left, because the right lung is bigger. And then if you're going to the right side, obviously the right side's going to get more because it's right side down. So you add 10 to that one, so that becomes 65. And then obviously you've got to take that 10 away, so the other one becomes 35. And when you go to the left, it's the other way around. The left lung gets 10 more, so the left lung becomes 55 and the right becomes 45. So B. Okay, next one. Now this one again I gave you on the one lung ventilation talk, and it's a little bit of a messy question, but essentially it's asking what is the first thing you're going to do to improve oxygenation during one lung anesthesia after you've gone to 100% oxygen. Do you apply 5 centimeters of CPAP to the non-dependent lung, that is the upper lung, 10 centimeters of CPAP to the non-dependent lung, 5 centimeters of PEEP to the dependent lung, 5 centimeters of water CPAP to the non-dependent lung, and 5 centimeters of PEEP to the dependent lung, or intermittently reinflate the non-dependent lung. So the dependent lung is obviously the one we're ventilating. So let's see what people say. So the answer is C, okay? And it's a messy question because really, as I said in the lecture, you should have already done this at the start, but the first step is PEEP. So PEEP to the dependent lung, the ventilated lung. The next step after PEEP to the dependent lung is putting the oxygen catheter down and giving some very gentle oxygen insufflation. And then the step after that would be some CPAP to the non-dependent lung, and 5 centimeters of water is too much. It would be 1 centimeter of water. And then the next step is going to be, after you've gone with a bit of CPAP, you might increase it to 2 or 3 centimeters of water. The next step will be asking the surgeon to if you can reinflate the lung. But as I said, often you can ask them to squeeze the pulmonary artery going to that lung to divert the blood to the lung you're ventilating. So the reason why you want to do PEEP first is because we want to get the lung close to the functional residual capacity, the FRC, and PEEP does that. The reason I don't like this question is because we should have already given PEEP at the start of the case, so you shouldn't have to do it. But I think that's what the examiners were angling for in my exam when they wrote this question. A few people have said CPAP. The thing I'd like to stress is that CPAP it's very messy for the surgeon. If you do apply 5 centimeters of water of CPAP, the lung does start to come up, and the surgeon does notice. So I've done it, like I mentioned in the one lung ventilation lecture. Only 10% of patients desaturate, and of those, most of them you solve with regular recruitment and then oxygen catheter. CPAP would be less than 5% of patients, and usually only 1 or 2 centimeters is necessary. And often you can buy some time by getting the surgeon to squeeze the pulmonary artery on that side. And if you really have to do CPAP, you have to do it. And intermittent reinflation of the lung. The only time I've really had to use that is lung transplants. That's really the only time. So so it's a little bit of a confusing question. I should probably rewrite this question at some point. But CPAP is still not the next step, and the next step would be oxygen catheter. So you'd want to run down all those steps, because CPAP, if you've ever done it, it really blows the lung up, and so you want to avoid it because the surgeon will complain. And if you put an epidural in this case, the surgeon's probably already mad at you for taking an extra 10 minutes. So you want to try and keep them happy. Okay, so this question refers to, again, one lung ventilation, asking which patient is most likely to desaturate significantly during one lung anesthesia. Is it the patient who's having a left-sided thoracotomy and they have a reasonable PO2 during two lung ventilation but poor preoperative spirometry? Is it the patient having a right-sided thoracotomy who has relatively poor PO2 values on two lung ventilation but good preoperative spirometry? Is it a patient having a left-sided thoracotomy has diminished perfusion on the VQ scan to the operative lung? Is it the patient having a right-sided thoracotomy who has relatively poor PO2 values during two lung ventilation and poor preoperative spirometry? So the answer is B. If you remember the risk factors for desaturation, one of them was right-sided surgery, so that means you're down to B or D. And the other one was patients who have normal preoperative spirometry are more likely to desaturate. So that means the answer will be B. Right-sided surgery because you're collapsing the right lung, which has most of the blood flow, and normal preoperative spirometry because those patients are more likely to desaturate. The patient who has diminished perfusion to the operative lung is less likely to desaturate because diminished perfusion means that that lung is probably contributing less function to their overall lung function. And this is one other one that you have seen before. Following a left pneumonectomy, a left intercostal drain is placed and connected to an underwater drainage system in the postoperative period. A leakage of air is expected from the drain. The patient should be nursed in the right lateral decubitus position. The underwater sealed drain should be left on continuous free drainage. The underwater sealed drain should be left on continuous free drainage and connected to wall suction. The underwater sealed drain should remain clamped and released for a short period every hour. So the answer is E. If you remember, we don't ever put these on suction, as we've just discussed. A leakage of air shouldn't really be expected because you don't have any you shouldn't have any source of air because the lung is gone unless you've got an abnormal leak from the bronchus that's been sutured. So that's bronchopleural fistula. So it shouldn't be A. Doesn't really matter which position you nurse these patients in. But if you've had a left-sided pneumonectomy, whether you put them right side down, I don't think it really matters. Continuous free drainage you want to avoid because you want the serous fluid to build up. So it is the best answer. I think this is the last one. During one lung ventilation can cause damage when sustained plateau pressures are greater than 20, 30, 40, or 50, or there is no relation to pressure. So if we go back all the way to our protective ventilation strategies, we'll see if we have a number there. Maybe I've gone too far. I don't think I have it on this slide, but it should be 30. So the answer is B. I mean, your peak pressures should not exceed 30. Your plateau pressures, I think, should not exceed 25. I'll just clarify that, but I'm pretty sure the answer is B. Yeah, 30. So in some patients, you may have to struggle a bit to get to ventilate lung if they have very bad lungs, but you never want to go above 30. So I'll just there's a difference between peak and plateau pressures as well. So I can't remember where I got this question from, but if you're giving 5 of PEEP, and then your ventilation pressures will be, I guess, greater than occasionally greater than 20 or 25. Yeah, I mean, my feeling is it should be 20 as well, but I'm just going to check that because when I look at my one lung ventilation slides, I think it is 20. But I think this answer comes from an extensive discussion for people sitting the Australian exams. So I might have to just double check that. Yeah, plateau pressure is less than 25, peak pressure is less than 35. So I think that's why people went for 30. Again, a lot of the questions that are written for the Australian exam come from some article, but I think 30 for a plateau pressure is a bit high. But you're not. But the wording of the question is sustained plateau pressures are greater than 30. So, as in, you'll damage the lungs if you give 30. So you're not going to give 30 or above. You can go up to 25 and peak pressures of 35. So if you have 5 of PEEP, then your inspiratory pressures are usually, you wouldn't go above 25. You technically can go up to 30 to have a peak pressure of 35, but you usually, I do get nervous going above 30 unless it's a lung transplant. Sometimes you go above 20. Ruba's asking if the 25 doesn't include PEEP. When your peak pressure is so if your PEEP is 5 and you have an inspiratory pressure of 30, that means your peak pressure will be 35. Your plateau pressure will always be lower than that. Your peak pressure is the pressure that opens the airway. That's when you look at your ventilator, the first pressure is the highest when you're on volume control, and then it drops to a plateau pressure. When you ventilate with pressure control, it's a little bit different, because if you set your inspiratory pressure of 20, it will open the lung to 20 and hold it at 20 for the duration of inspiration. So your peak and plateau pressure shouldn't be as disparate. But with volume control, your peak pressure is the first pressure when you start putting the volume in the lung. So they're both added on top of the PEEP, but if you've dialed in, say, an inspiratory pressure of 20, that should be your peak pressure, and your plateau pressure should be less than that. Ruba, you have some questions. I'll just turn on your microphone. So look at how to do this.
Hi.
Go ahead.
Thank you for the lecture. It's great. My first question was about if the patient does have a superior vena cava syndrome. Besides the lower limb venous cannulation, what other considerations should we be ready for? And the other question was about the jet ventilation for the mediostenoscopy. Does the ventilation have to be jet ventilation, or can we use other methods like Jacksonian ventilation or Ambubag, or even the manual ventilation of the ventilator? Thank you.
Yeah, so I'll answer the second question first. The jet ventilation, mediostenoscopy, you ventilate normally. Mediostenoscopy, you ventilate. Just go back to that picture of the mediostenoscopy. Mediostenoscopy, you can ventilate normally because they're in the mediastinum.
No, I mean
bronchoscopy.
If we have to use the jet ventilation.
Yep. So one of the problems is if they have to stick a rigid bronchoscope down. That's if you lose your airway on induction and they have to stick a rigid bronchoscope down. Then you can try other things. The problem is when the bronchoscope is in the airway, there's a huge leak around the bronchoscope usually. So when you connect up your circuit or an Ambubag or whatever you connect, because they have a side port, a lot of the air can leak out. The surgeon can close the bronchoscope so that it doesn't all leak out. But usually the airway is bigger unless they have some sort of stenosis of the airway that'll prevent the air leaking out. But for the most part, when I've tried to ventilate an adult down a bronchoscope, it's difficult, and so that's why jet ventilation is easier, because you're putting a high pressure air and you don't have such a leak. The problem when you do it with on your circuit is you squeeze the bag and most of the air just leaks out around the bronchoscope. It doesn't go down the airway. So that's why I was saying you can do it, but you've got to hold the oxygen flush button a lot of the time down to get the air down. And now I assume that would be the same if you try to use an Ambubag or something else. Regarding superior vena cava syndrome, there's not a lot you can do. They bleed. They may bleed a lot more if they're operating above the superior vena cava because of the reduced venous drainage. and the surgeon at some point may clamp the superior vena cava, which may mean facial edema and upper airway edema, and you may need to see if the surgeon's happy for you to have a bit of reverse Trendelenburg, so the patient's a little bit head up to aid the drainage when after they've finished operating on the superior vena cava. In some of these patients, if they are very short of breath, you may need to pre-oxygenate them sitting up and gas them down sitting up, and then gradually lie them down until they can tolerate. Until they're asleep, and then obviously they're not going to get distressed, and then take over their airway. But there's not a lot you can do until the surgeon fixes the problem, and that is resecting the mass. And sometimes they have to tie off the SVC while they do that and reconnect it.
Thank you.
Okay, no worries. Any other questions? Okay, so that's thoracic surgery in a nutshell. I know a few people have asked about hypothermia in the operating room. I do have a few slides on that I can quickly run through now if people want. Otherwise, we can leave it. But it's just a topical issue relating to the Facebook post. A few people had asked me for a bit more information about it, so people can write on the notes if they're interested. And I've only got about 9 or 10 slides. Should take only 10 or 15 minutes if people are interested. We can do that. Okay, Dr. Hafez has said yes. Any advances? Okay, sorry, I'm just got to get that presentation up.
I want to say something about the hypothermia.
Yep, go ahead.
Is that we used to have fights in the hospital in Jerusalem with the surgeons about the hypothermia, because the surgeons like to have air conditioning during the operation, and their excuse was they need to put the patient hypothermic to prevent infection. But I know that hypothermia will increase the infection, so is that true?
Yeah, that's a good point. I often used to walk into orthopedic rooms, and if there's one group of surgeons that seem to make up their own evidence,
orthopedic. Yes, orthopedic.
It's like 12 degrees in there, and you think, what are we going to? We're trying to freeze the bacteria. Is that what this is about? But there's excellent evidence, I think, that hypothermia increases wound infection, which kind of makes sense in a way. I mean, one of the ways we fight infection is by having our blood cells arrive at the sites, and our immune system acts. And if we're extremely vasoconstricted, that's not going to happen. But there's lots of evidence showing that, and lots of studies out there. Let me just find this. Yeah, showing that it increases the infection risk. So I think telling the surgeons to harden up. First of all, that if the surgeons get hot, I understand that. I understand that some surgeons are fat and they get hot. I do understand that, but I have no sympathy when it's a pediatric patient. I have very little sympathy when it's a prolonged case, because I understand the surgeon has to operate and they can't operate if they get hot and sweaty, but then they can take a break, okay? They can go outside, they can get sponged down by some very obliging nurse, but it's unacceptable. Like this case we had on Wednesday or a Friday or Thursday, it was unacceptable to have 34 for. I mean, it really was. And we tried some things, and we did what we could. We definitely could have done better at the start of the case and had the room warmer. But that's a huge risk in a patient having prosthetic rods put in, like metal rods put in their back, which if they get infected, it's a disaster. And the surgeon's very anal about masks and everything else. But to have a temperature that bad, I feel I'll feel incredibly terrible if that patient gets an infection, because I mean, it's something that we should be able to prevent. And certainly, if we're going to be doing more spines, hopefully we as anaesthesia get involved beforehand, and we come up with some strategies before we start the week to minimise the temperature. And we sometimes we just have to be hard on the surgeon. And it's not, I'm not trying to be rude to them. It's just that, there's times where you can tolerate it. If it's gynecology or something, sure, okay, that they don't get a lot of infections. The vagina is a vascular area. But, I mean, this particular surgeon was quite a large guy, and one of his assistants was saying in the US he wears an ice vest under his gown because he gets hot. I mean, sometimes you have scrub nurses who are perimenopausal and they get hot, so they have the room temperature really cold. If you have a way of keeping the patient warm, then sure, that's fine. I mean, we often have to be a bit uncomfortable and be cold because we're not under the lights and we're not wearing a big gown, and we accept that as long as our patient's temperature is okay. But we're really there for the patient. So I think if it's putting the patient at risk, I think we have to put our foot down. And the one thing we have in our favour is we're not scrubbed, so we can go and turn the air conditioning off or turn the temperature up, and the surgeon can't do that. Unfortunately, most of the nurses are on the surgeon's side, and so when the surgeon complains, they turn the temperature down. My technique, and unfortunately this didn't work in Raphidia because the air conditioning seemed to be all or nothing, but my technique in Australia is to just gradually turn the heat up a little bit at a time, because if you do it too fast, everyone notices. But if you turn it up half a degree at a time, and half a degree, by the time the surgeon notices, you've had an hour of a warm room, which has helped bring at least hopefully help bring the patient temperature up. So, but yeah, it's a problem worldwide. And I mean, at least in Australia, we have Bear Huggers, which are the radiant convection warmers, the convection warmers, and we have radiant warmers, and we have, I guess, more techniques at our disposal for heating the kids up. But it's a huge problem. And I'll just quickly run through these slides before we run out of time, just so you can see some of the risks. And I'll just say, and I was telling Mustafa this today, there is a website which is called the National Institute of Clinical Excellence, or NICE, N-I-C-E, and they put out guidelines on certain things that they think are issues that we should be aware of, and they're evidence-based guidelines. They're free to download, and they're very good. And their hypothermic guidelines in the operating room are very good. So if you go to their website, if you just look up NICE guidelines or NICE guidelines, you can download them. But just in short, hypothermia is defined as a temperature of below 35 degrees. The body will respond by voluntary or involuntary muscle contraction to increase heat production. Shivering is involuntary muscle contraction, and that increases heat production fivefold, but it uses up energy and shiver. Non-shivering thermogenesis produces heat by metabolizing brown fat, and probably also increases metabolism in liver and muscle, and that's what babies use. They have non-shivering thermogenesis. And people in cold climates have a higher BMR than people in temperate climates. So if you live in a cold climate, your basal metabolic rate is higher, and that allows you to produce more heat. And people that live in hot climates have a lower basal metabolic rate. That's probably why if you ever go to a tropical country, everything just happens a little bit more slowly because people's metabolism is slow. Everything there is slow. So when we talk about thermoregulation, we talk about a core compartment and a peripheral compartment. And the core compartment is things like the heart, the lungs, the brain, and the peripheral compartment and the skin and the muscles. And it's estimated that the core compartment occupies 66% of our body mass for temperature at rest, and the remainder is in the periphery. When we give a general anesthetic, we cause peripheral vasodilation, and that accelerates the transfer of heat from the core to the periphery, because obviously if you dilate the veins, more blood goes there, and that blood takes the heat with it. And so you get the heat moving from the core to the periphery, and that causes cooling of the core compartment, and the core compartment expands in size. Peripheral compartment warms and contracts by a corresponding amount because you're putting warm blood into the peripheral compartment. When we give someone a general anesthetic, so we do not only do we shift the heat from the core to the periphery and cause loss of heat, we also impair central thermoregulation. So our anesthetic agents actually impair the ability of the brain to thermoregulate. And if you remember, the first part of this talk I've skipped ahead because I just wanted to get to the hypothermia part. But our temperature is regulated in the brain by the hypothalamus, and it has what we call the hypothalamic set point, and that is where our brain decides whether we're hot or cold, and that's what gets affected when we have a fever. But and general anesthetic impairs this. But mild to moderate hypothermia can increase myocardial oxygen workload, impairs oxygen delivery, and impairs coagulation. So these are all things that surgeons don't like, and impaired oxygen delivery is one of the reasons why we get a higher risk of wound infection and tissue ischemia. This graph is very important, and this graph just shows heat loss under anesthesia. So if you look at the time and the body temperature, there's 3 phases of heat loss. The most of the heat loss occurs in the first 30 to 60 minutes. That's from our induction drugs and our first sort of 15 or 20 minutes with our maintenance drugs. But we get, we get what we call phase 1 heat loss, which is quite steep. Phase 2, it slows down, and then phase 3, it plateaus. So when we're trying to prevent or reduce the loss of heat in phase 1, we really should have the room warm at the start of the case. We should have the patient covered and start our bear hugger. Now, in Australia, the surgeons don't like the bear hugger until they put their drapes on, and that's because the bear hugger, it's essentially like if you can imagine like a big rectangle blanket. It has little little lines with like little plastic domes, like plastic. If you ever see those hydroponic domes that you see around farms around here, it's kind of like got a whole lot of longitudinal domes, and you shoot warm air down with a massive hairdryer, and that provides a warm air near the patient, and then that warms the air next to the patient, and then that warms the patient. So it's very Bear Hugger is just a brand name, but they're called convection warmers. Unfortunately, I don't have a photo, but that's our major way of warming patients. But the other way we do it is turning up the room temperature, particularly if it's a baby. If it's a baby, we also have a radiant warmer, which is what the humidicribs that we do our neonatal resus in. They have a warmer over the head, over top. We have a portable warmer we put over the top for babies, particularly when they're under a month old. So all of those things can help slow the heat loss during that first phase, and then once the drapes are on, keeping the patient warm hopefully slows the heat loss in the second phase. And as you see, it starts to plateau, but you can get gradual creep of heat loss during the case. So phase 1 is mostly due to the redistribution. So that's when we talked about dilation of blood vessels after anesthetic induction, causing blood to move from the core to the periphery. And the core temperature initially falls about 1 degree over an hour. So keep this in mind. If you have a patient, if it's an elective patient, they shouldn't be that cold. But if they've been waiting in a cold room for a while, their temp might be 36. And then you can get them to 35 after induction. So a degree over an hour is quite a big drop in temperature. Although the core temperature initially falls, body heat content, that is the total amount of heat in your body, does take a little bit longer to change because the organs have to get cold because everything's in equilibrium and they will still retain some heat. But that 1 degree over 1 hour is quite dramatic, and it often will depend on where your patient's starting. So if your patient is a trauma patient, they're often cold already. So obviously, especially if they had a lot of cold blood, obviously 1 degree of an hour in them could take them down from, say, 35.5 to 34.5, and you're already in trouble. Then phase 2 is the linear heat loss. So that's phase 2, linear heat loss or decline, and that's more gradual, and they lose another 1 to 2 degrees over a couple of hours. And that's due to a combination of sustained vasodilation with our anesthetic drugs, exposure of the patient with the surgeon's prep, and often if they're using alcohol, they'll lose a lot of heat. Cold operating room environment. So again, if we can stop this getting too cold, we can slow that down. And often the bed's cold. All of these things, they put that cold metal cautery pad on. This all saps heat from the patient. And the one thing I will say about the spine team and some surgeons I work with in North America, they are incredibly slow to get the drapes on. Like it can be 30 to 60 minutes between when they prep and when they get the drapes on, and all the time the patients are losing heat. Conversely, if you're having a minimally invasive surgery like tonsils or something really minor, and they put lots of drapes on, the patients can actually get hot. So they can, under those drapes, be quite comfortable. But if it's a massive exposure, big prepped area, and long time to get the patient covered, then the temperature drops. And then there's the plateau phase. And this occurs once the temperature falls below the thermoregulatory threshold. Peripheral vasoconstriction will act. So your body will start to vasoconstrict despite all the drugs on board to limit heat transfer from the core to the periphery. And so we're always at a thermal equilibrium, and we sit around 37. But now under anesthesia, we establish an equilibrium at a lower temperature. Okay, and that's just the basic explanations of why that happens. There are 4 major modes of heat loss: radiation, convection, conduction, and evaporation. Radiation is the major one in the operating room. Radiation is just heat being lost to the atmosphere. And if the room is cold, it's obviously going to be lost faster. So the walls are cold, the roof is cold, and we radiate heat to those parts of the operating room. And 40% of our heat loss comes from radiation, and it's proportional to the core temperature to the operating room temperature difference to the power of 4. That is, if your core, say, is 37 and the operating room is 22 or 18, that difference is, the bigger that difference, the faster you're going to lose heat to radiation, and it's to the power of 4. So if you've got a 10-degree difference, that's 10 to the power of 4 affects your radiation. So having a cold room makes a huge difference to how fast the patient loses heat. So the other ways in order of importance are convection. So that's heat loss to air immediately around the body. So we have a convection all the time happening, right? If there's a cold wind outside blowing, you get cold, and one of the reasons is it's convection. The wind makes the air around your body cold, you lose heat to that air, and it's rapidly whooshed away by the wind, and then new air comes and you warm that air, and so on, and that's why you get cold, and that's convection. So if you have cold air, again, a cold room, cold air around the patient, they will lose heat, and that's 30% heat loss. The idea behind a convection warmer is to warm that air by putting the hairdryer blanket, the convection warmer around the patient. You heat that air, and then you can reverse that and start to reheat the patient. And we see that a lot. They're very effective. There's other things you can get as well, like warming mattresses to put on the operating table. They can help convection a little bit, but more often they help conduction. So conduction is when you lose heat to something you're directly in contact with. So that's the mattress. That's if the surgeon's prep. If there's water or blood underneath the patient, that gets cold, and then the patient loses heat to that. And that's why often for big bloody cases we use like those blue sheets that you guys have that absorb stuff. They're blue on one side, white on the other. We put a massive absorptive sheet underneath, like a big nappy or diaper, and that absorbs all the blood, hopefully, and wash that falls under the patient. And the other way patients can conduct heat to cold fluids is if the surgeons are using cold wash. So if the surgeons use warm wash, then that prevents a lot of heat loss. I mean, if you have your peritoneal cavity and they put 3 liters of wash, patients get cold very, very fast. The final way is evaporation. So again, if they use an alcohol prep, if they evaporate, if they have exposed serosal surfaces, so like bowel, liver, lung, they lose heat to that. And the evaporation, as I think the next slide shows, I'm hoping the next slide shows, becomes more important as the case progresses. And then there's insensible losses of water, respiratory tract losses. So if you have a insensible losses of heat. If you have a heat and moisture exchanger on the end of your endotracheal tube, which we don't have, that keeps a lot of the heat. So when the patient breathes out, it traps the heat, and they breathe in, the heat comes back. If you don't have that, when the patient breathes out, they lose heat. They breathe in fresh gas, and that's cold, and they've got to heat that. So they lose air that way, and that obviously gets worse the longer the case goes on. And we have to humidify all that air if you don't have a humidifier on your circuit. And humidification requires heat. So that's that can contribute, and that's something that, for longer cases, if we had some heat and moisture exchanges, we could select to use them in those cases. So I don't have that graph I was thinking of, but anesthetic factors, so where we contribute. So as I mentioned, we give our drugs that cause vasodilation. All our induction agents and our volatiles vasodilate, and so we can get a rapid drop below 35 degrees. Remember, 35 degrees is the definition of hypothermia. Now, we would normally shiver, but if we're under anesthesia, we change our set point, and we also paralyze our patients a lot of the time, and then they can't shiver. We give cold fluid, we give cold blood, and all of those things drop the patient's temperature. Now, this is a really interesting statistic. For every 1 litre of crystalloid at room temperature, which for argument's sake is 22 degrees, the body temperature can fall by 1 degree. That's huge. If you have a big case and you're giving 4 litres of fluid and it's all at room temperature, you could cause your patient's body temperature, if they're normal size, obviously it depends how fast you give the fluid, but if you're giving it stat, like rapidly, that can fall significantly. So, cases where we have to give lots of volume very quickly, like a bleeding cesarean section or something like that, we really need to have some warm fluids or a way of warming the fluid before it gets to the patient. Some of you might have seen the fluid warmer that we MacGyvered. MacGyver's a TV show from the late 80s, early 90s, and he was very good at rigging things to work with a pen, a pencil, and a bit of tape. And we put some hot water in an empty saline bottle and ran our blood tubing through it to try and warm our blood. And it worked reasonably well, I think. There's ways we can try and warm the fluid. But ideally, if we can put the whole bottle in a warmer before we give it to the patient, that helps. And infants are at the highest risk of hypothermia because their body surface area relative to their core is big. They have big heads, and they're chubby. They have a lot of surface that loses heat, and so they get cold quickly. And as always, it's the very young and the very old. Elderly patients too. Often they're very thin, and they lose heat very quickly. So all of those things are negatives about general anesthetics. What about regional anesthetics? Well, if we give a regional anesthetic, like a spinal, we have decreased afferent signals from the area below the block. So we've blocked the cold sensation, so our body doesn't know it's cold, so there's no vasoconstriction or shivering. And as you know, you get vasodilation below the level of the block. That's why we get hypotension. We don't get a plateau phase because we block the vasoconstriction. Remember, on this graph, there's the plateau phase where your body automatically starts to vasoconstrict and stop the loss of heat, setting a new equilibrium. We ablate that with a regional anesthetic. In the dermatomes we haven't blocked, such as above where we've got our spinal working, we can still shiver and get vasoconstriction. But as you know, we cause a huge shift of blood flow to the vasodilated segments at the level of our block, and so it can be as bad as with a general anesthetic. So if you give a regional and a general together, patients can get very cold, and people do it. People give a spinal for analgesia, and then put the patient off to sleep. So it's important to just bear in mind, if we are doing a regional or even a big peripheral nerve block, say you block a whole leg, a sciatic or a femoral sciatic, and you put the patient off to sleep, you increase the risk of heat loss. So you just have to be more vigilant. It's not the end of the world, but you've got to be more vigilant in combating the heat loss, keeping them warm. The surgical factors. So those of you who work with me, I try to impress on you good ways to classify lists, because when you're studying for exams, you end up learning a lot of lists. One of the ways we do it for anesthetics, anytime there's something that can be caused by the surgeon, caused by us, or just caused by the patient, we divide it into anesthetic, surgical, and patient factors. So these are the anesthetic factors we just talked about. Now, I'm going to talk about the surgical factors. So as I mentioned before, cold prep solution, patient being exposed, patients on wet drapes. If it's a big incision, large exposed serosal surfaces, and surgeons using cold wash. And then patient factors I would put in the next slide, which I don't have, but that's things like if the patient's already hypothermic, that's bad. If the patient's shocked and lost a lot of blood, required a lot of fluid, very old and very young, those are the risk factors. So what happens when we get cold? And a lot of the guys I've talked to at Raphidia are already aware of these things, but just to recap, less than 35 degrees, we get muscle weakness, which prolongs our neuromuscular blocking drugs as well. We get reduced shivering. Below 34 degrees, our patients get confused. At 30 to 32 degrees, we get loss of consciousness and bradycardia. And at less than 28 degrees, patients get arrhythmias and can get ventricular fibrillation. So arrhythmias at less than 28 degrees, that's why they say you're not dead until you're warm and dead, because if a patient's arrested and they're cold, you need to warm them up and while doing CPR and see if their circulation returns. So if you're very cold and arrested, we do this in cardiac surgery. We do deep hypothermic circulatory arrest. You have reduced brain and organ function, so you can get away with a few minutes of being arrested. But then as the patient warms up, you need to reestablish circulation. But the point is that below 35 degrees is very easy to get to this point, and even below 34. Very rare to get below 34, I think, in the operating room, unless you're giving lots and lots of cold fluid. So what are the other adverse effects of hypothermia? Well, we know below 34 we get confusion and poor memory and prolonged neuromuscular blockade. So this is done by organ system. In the cardiovascular system, we get arrhythmias and the blood becomes more viscous, which means it's sluggish circulation. From a respiratory point of view, oxygen hemoglobin dissociation curve shifts to the left, meaning that we reduce oxygen delivery to the tissues. Okay, so that increases our risk of tissue ischemia and increases the risk of wound infection. If we shiver, we get increased oxygen consumption. I think someone made that point before. So if your patient has ischemic heart disease or has poor cardiac output because they have some cardiac failure and they start shivering, their heart system, the cardiovascular system, will be under a bit of stress. Likewise, if they have poor lung function, because they need to increase their functional reserve to compensate for this, and they may not be able to. The kidneys, we have reduced blood flow to the kidneys with vasoconstriction, reduced glomerular filtration rate, reduced tubular function, and reduced drug clearance. So some drugs, may hang around more. We get reduced cellular metabolism, reduced enzyme function, but most important one here at below 34 is coagulopathy. Patients bleed more. We know from studies there's poor wound healing, longer hospital stays, and increased blood loss. So, it'd be nice if we could show the surgeons that don't want us to warm the room some articles. But since every time we say to them there's no evidence for that, and they say to us, well, not everything has to be evidence-based, we shouldn't have to justify this stuff. We should just be able to say, well, not everything's evidence-based, but this actually is evidence-based. There are studies out there showing poor wound healing, longer hospital stays, and increased blood loss if they get hypothermia. So what can we do about it? And we've talked about some of these things already and also on the Facebook page. that HME, heat and moisture exchanger, using warm fluids, warming our blood, using absorbent undersheets. Those are those things I was talking about before, like a big diaper underneath the patient that absorbs all the blood and wet stuff. Warming blankets we talked about. Radiant warmers for infants. Increasing the room temperature, which is obviously a source of contention. And monitoring temperature, I forgot to mention that. I don't know what you guys are like at the other hospitals, but I think at Raphidia we have 2 new machines which have temperature monitoring devices, I believe thermometers they're commonly referred to. Ironically, the pediatric room is not one of those rooms. I did find a temperature probe in the pediatric room, but it didn't fit that machine. I'm not sure if anyone knew which machine it fit, but if you don't monitor the temperature, then it does make it a bit harder to express alarm to the surgeon, because they'll say, what's the temperature? And you will say, I don't know. And they'll say, you're giving me such a hard time and you're not even measuring the temperature. So it's really important for long cases and for children. I mean, you don't need to measure the temperature for everyone. I think I read somewhere that if the case is going to go for more than 45 minutes, you should measure the temperature. And I would go one step further than that to say if it's a neonatal case, I would certainly, or even under 6 months, I would try and measure the temperature, even for cases only going 30 minutes, because they can get cold very, very fast. But generally 45 minutes or more. If it's a 1 hour case and it's a big patient, okay, maybe you don't have to measure the temperature. But for the most part, longer cases. And if you're going to warm the patient with a convection warmer, which in Australia is pretty much routine for most cases, I like to monitor the temperature, because at the same time, I don't want to make them too hot. It's not healthy to make someone's temperature go up to 38 either. So these are from the NICE guidelines, which I mentioned at the start of this talk. In the preoperative phase, what can we do? Well, we should assess each patient's risk for inadvertent hypothermia and the consequences before we even take them into the operating room. So this is part of our preoperative assessment. When we're seeing these patients before they come into the operating room, we should be flagging which patients are at risk. If we see a baby, we think, okay, this patient's at risk. If they're having a big operation where we anticipate lots of fluid being given, they're at risk. So just have a high index of suspicion of which patients are going to be at risk. If they're a 100-kilo, 20-year-old big guy having his broken arm fixed, he's probably not going to be at risk because he's got a lot of padding. So just be aware of which patients we need to get into a fight with the surgeon about, because we don't want to fight with them all the time. So these are some guidelines. The patient should be managed as high risk if any of the 2 of the following apply. So if they're ASA 2 or above, essentially 3, 4, or 5, the higher the ASA grade, the higher the risk of hypothermia. If they're already cold preoperatively and we don't have time to warm them up, so the patients, for example, if they come from the emergency department, then we'll we may need to warm them up. Rwanda has just asked a question. I'll come back to that, Rwanda. I'll just finish these risk factors. If they haven't combined general and regional anesthesia, as we talked about, they're at higher risk. If they're undergoing what we could define as major or intermediate surgery, so things like cardiac surgery, major abdominal surgery, thoracic surgery, those are all higher risk. And if they have a risk of cardiovascular complications, because remember, if they shiver, now they may not shiver in the operating room, remember, because we've paralyzed them and we've impaired their ability to shiver, but they'll wake up shivering. And if they wake up shivering, we drop them in recovery and they're cold in recovery and they're shivering in recovery, what does that do to their oxygen requirements? It pushes them right up. And if they have ischemic heart disease, then we've added another factor that these people have to deal with. So just be mindful of the cardiac patients. So Rwanda asked where we put the temperature probe. Look, there's a lot of debate about this. I usually put it. Ideally, the esophagus gives you a core temperature. I usually put it oropharyngeally, sometimes nasopharyngeal probe. The reason I go oropharyngeal first is because you can traumatize the nose with with a nasal probe, and so if I can avoid it, I will. It's just that sometimes when you try and stick it in the mouth, it doesn't want to go into the esophagus, and at least if you can go down the nasopharynx, you get a more direct line into the esophagus. So I'll sometimes put it there. People do put them in the axilla. I don't like it in the axilla because I've seen them get pushed out the back of the axilla, and then it's not accurate. And also, if the arms are not by the patient's side, it's not accurate. We know axillary temperature reads about at least half a degree below core temperature. Rectal temperature takes a long time to change. So I can't remember the exact time course, but I think there's definitely a delay between when rectal temperature and core temperature, and you see this when you do cardiac surgery. We often have an esophageal probe, and I think we sometimes put a rectal or a probe in as well, and there's a delay. A lot of the newer Foley catheters have temperature probes on them, so if we're doing a big case, we often just connect our temperature. We often just connect our temperature probe to the one in the bladder, and then we have a very good measure of core temperature. So Hafez has commented the best place between the lower 1/3 and proximal 2/3 of the esophagus next to the aortic arch. Yes, I've read that. I mean, you want to be close to the central blood supply because that gives you the best index of core temperature. But it also depends on the case. I mean, if you've got some of the newer, fancier central lines have temperature probes in them because it allows you to do cardiac output. So if you can measure the temperature of blood going past the pulmonary artery, that's a pretty accurate core temperature. So if the patient's got a central line or a pulmonary arterial line with a probe in, I think that's good. If you can get a bladder temperature, I think that it's reasonably reliable. But it's also a trend thing too, like a lot of things. If your starting temperature, even if it's nasopharynx, is 36, that might be under reading compared to the core. But if it drops to 32, there's a good chance your patient's got very cold. The only thing I will say is they do get moved, they do get dislodged. So I often do check under the drapes, because if it's been pulled out and it's sitting under the drapes and it's reading 34, it may be reading the temperature just outside the patient's head rather than in their esophagus. But generally, yeah, nasopharynx, oropharynx, ideally in the esophagus if you can get it down there, and then I just when I worked in Michigan, they always put it in the axilla, and I just hated it because I never trusted it. You can sometimes get reliable temperatures, but they're always at least half a degree under core. And rectal is generally not considered that helpful, especially if they have feces in their rectum, because it insulates the temperature probe and takes a lot longer for the temperature to drop. So again, this is from the NICE guidelines. So they're saying, so remember they said we should assess patients and we should manage them before they come into the operating room. If we get a pre-op temperature below 36, we should initiate warming before the operation starts. So in the anaesthetic bay or in the emergency department, warm them up unless the surgery is so urgent we cannot wait. And then we keep the warming process going on during surgery. During the operation, we should measure the temperature at the start, but before induction, and then every 30 minutes until the end of surgery. We shouldn't induce them unless their body temperature is above 36. I just want to point out, this is ideal management, okay? Not everyone can do this stuff, but it's just some guidelines in place, and we try and follow as many as we can. If we don't have a temperature probe, we don't have a temperature probe. These things don't grow on trees. They can be expensive, but it's just something to strive for. Get a few more temperature probes, and then if you only have 2 or 3, you select. You might say, okay, 7-hour case, lots of bleeding. Maybe we can get it done in the operating room where we have the ability to monitor temperature. So it just gives you an idea of what we can try and do to do the best thing to prevent this problem. If we're going to give more than half a litre of fluid, or we're going to give blood products, we need to warm them using a fluid warming device to 37 degrees. And then those patients we selected out already as higher risk for preoperative hypothermia should be warmed intraoperatively, even if they're having anesthesia for less than 30 minutes. We should warm them from induction until we wake them up. If the operation is going for longer than 30 minutes, then we should warm everyone regardless of risk. This is what the NICE guidelines say. If I'm just doing ear tubes or tonsils, I'm not going to warm the patient for the most of the time. Some of the surgical trainees are very slow, and you might regret that, but they're going to be covered up, so I guess you can use your discretion. But it's a good principle that if the surgery is more than 30 minutes, we should have some sort of warming devices in place. So we should always measure the temperature on arrival in the recovery room, and this is very important. And in children, I'm often very interested to see the temperature, because if I think the patient was a bit cold, I want to see what the temperature is in recovery. I'm very cynical about the recovery temperatures in Australia because they use those infrared ear probes, and they always read 36.5 no matter what. If my temperature was 38.5 in the operating room or 34, they get to recovery and it's always 36.5, and so I don't believe them. But having said that, when they say the kid's cold, I do believe it because they usually overread. So but for some reason those are the probes they use. You're only as accurate as your temperature probe. I think that's something that's important. Those infrared temperature probes are designed to read the tympanic membrane, and they give a very rapid temperature reading, and they're actually very accurate. But they're only accurate if there's no wax in the kid's ear and if it's pointed directly at the tympanic membrane. The problem is most of our nurses are not trained in that knowledge, and so they just stick it in the corner of the kid's ear and they get a temperature, and they don't actually retract the outer ear like you would if you're trying to get to the tympanic membrane and point at the tympanic membrane. And that's one of the reasons why I don't believe those thermometers, because I just can't understand how I can have a kid who's 38 degrees in the operating room, and in the 100 meters it takes me to get to the recovery room or less, the temperature is miraculously 36.5. It just doesn't make sense. So if I am really worried about a kid's temperature, I'll usually take it myself and take it 4 or 5 times until it gives me a number I believe. We shouldn't be transferring patients to the ward unless the patient's temperature is 36. So remember, the ward doesn't have the nurses to watch kids closely. Like they might have one nurse to 4 or 6 patients, kids or adults for that matter, and they don't have the warming devices. So we need to try and sort this problem out in the recovery room, and that's really important. And recovery rooms should be warm, okay? They should be really warm. They shouldn't be cold, because there's no excuse now. No one's operating on them. It's a great chance for patients to warm up. If the patient's temperature is below 36, they should be actively warmed using forced air warming until they're discharged from the recovery room. So essentially what these guidelines are saying is if they're cold pre-op or less than 36 pre-op, we start warming then. If they're less than 36 intra-op, we're definitely warming, and we continue that warming into the recovery room. So just a summary, body temperature is maintained at 37 plus or minus 0.2. The highest risk patients are the elderly, the critically ill, and the infants. Anesthesia impairs the body's ability to thermoregulate. Large operations can cause significant heat loss. We monitor temperature for all but the shortest procedures, and we should warm cases over 30 minutes. That's what the NICE guidelines recommends. We tend to use 45 minutes where I come from. And if they're ASA 3, 4, or 5, we start warming even if it's only a short case of less than 30 minutes. Okay, are there any questions about that, or anyone have anything they want to discuss? I'm just going to see if I have a slide on temperature measuring sites. I just can't remember. No, I don't. Okay.
Derek,
Yep.
this is Hafiz Sami. I would like to steal the podium from you. I would like to steal